Welcome to this explainer. Okay, today we are officially putting on our medical detective hats to investigate a group of notorious viral culprits. We're talking about the alphabet soup of viral hepatitis, viruses A, B, C, D, and E. Now, what's wild is that these 5 pathogens all target the exact same organ, but they operate in entirely different ways, with wildly different consequences for the patient. We're going to break down the exact pathology and clinical management of these viruses so you know exactly what to look for. Before we identify our specific suspects, we really need to establish what the crime actually is. Hepatitis, quite literally, just means inflammation of the liver parenchyma, the functional tissue of the liver. And while toxins, drugs, or autoimmune issues can certainly cause this, viral infections are by far the most common and critical culprits we'll be discussing. Now, timing is absolutely everything here. We classify this inflammation completely based on the clock. Acute hepatitis lasts for less than 6 months, while chronic hepatitis persists for more than 6 months. Keep that 6-month threshold in your head. It's a vital dividing line for how these diseases actually play out. Okay, let's dive right into this. Here is our agenda for the investigation. 1. The suspects. 2. Modus operandi. 3. The evidence. And 4. The resolution.
Let's pull up the profiles on our 5 main suspects and look for the patterns and the outliers. Hepatitis A and E are both RNA viruses transmitted through the fecal-oral route, so usually contaminated food or water. Hepatitis C is also an RNA virus, but it's bloodborne, often transmitted via IV drug use. But hepatitis B? Well, it's the grand exception. HBV is a partially double-stranded DNA virus from the hepatinovirus family. And, remarkably, it actually contains the reverse transcriptase enzyme, meaning it can convert its RNA back into DNA. It's transmitted through blood, sexual contact, and from mother to child. Understanding these fundamental genetic and transmission differences, that's your key to predicting how these viruses behave in the wild.
Now listen up, because I want to highlight a massive red flag regarding hepatitis E. While A and E are usually self-limiting and really don't become chronic, HEV is uniquely and severely dangerous for pregnant women, particularly when contracted during the 3rd trimester. In this specific population, hepatitis E can trigger fulminant hepatic failure, which is a rapid, massive loss of liver function, and it carries a devastatingly high maternal mortality rate. It is an absolute must-know detail that dramatically changes the stakes of an HEV diagnosis.
And then we have hepatitis D. This one is fascinating because it operates like a dependent parasite. HAV, HBV, HCV, and HEV are all independent. They can infect you entirely on their own. But HDV, it's a defective RNA virus. It literally cannot survive or replicate independently. No way, it has to hijack the hepatitis B surface antigen to function at all. Because of this, you can only get hepatitis D if you already have or simultaneously contract hepatitis B. This can happen as a simultaneous co-infection, or worse, a superinfection, where HDV crashes an existing chronic HBV infection, leading to a much, much more severe clinical outcome.
Modus operandi, pathogenesis, and clinical phases.
You'd probably assume the virus is just directly chewing up the liver cells, right? Well, actually, scratch that. A core concept of viral hepatitis is that the damage is almost entirely immune-mediated. It's a classic case of friendly fire. The virus enters and infects the hepatocytes, sure, but it's actually our own immune system, specifically the cytotoxic CD8 T cells, basically our immune system's special forces, that recognize the infection and attack the compromised liver cells. This fierce immune response is exactly what causes the hepatocyte injury, the intense inflammation, and eventually the cellular necrosis. So what does this microscopic battlefield actually look like for the patient? Well, in an acute infection, it unfolds in 3 distinct acts. First is the prodromal phase, and you feel absolutely awful. Fever, extreme fatigue, nausea, vomiting. It feels like a really severe flu. Then comes the icteric phase, and this is where the liver's distress becomes highly visible. Patients develop jaundice, literally turning their skin and eyes yellow. Their urine turns dark and their stools become pale, usually alongside a swollen, enlarged liver. Finally, in most acute cases, we reach the recovery phase, where all these dramatic symptoms gradually resolve as the immune system successfully clears the virus. But, not all infections end in that nice, neat recovery phase. We really have to draw a hard line between acute and chronic hepatitis. Hepatitis A and E are almost always acute. They run their course in less than 6 months, and the patient makes a complete recovery. But hepatitis C and sometimes hepatitis B, well, they're insidious. Because of things like HCV's incredibly high mutation rate, the immune system fails to clear it. The infection slips right past that 6-month mark and into chronic hepatitis. It often remains completely asymptomatic for years, silently maintaining persistent inflammation that eventually leads to devastating structural changes in the liver.
The evidence, diagnostic labs, and histopathology. Let's look at the labs and see how this builds our clinical picture. Our primary clues come from liver function tests, or LFTs. We look at the aminotransferases ALT and AST. While both of them elevate during liver inflammation, ALT is the real star here. It is much more specific for liver injury. Elevated bilirubin confirms exactly why the patient is jaundiced, but perhaps the absolutely most critical number to watch is the PT/INR. This measures blood clotting. If the PT is prolonged, it means the liver has completely lost its synthetic function, its ability to manufacture things. It's failing to make clotting factors, which is a massive, blinking red flag for severe, potentially life-threatening liver dysfunction.
Now, what's really interesting here is that hepatitis B serology is famously complex, but it cracks the code and tells a perfect story if you just know how to read it. HBsAg is the surface antigen. If it's there, the virus is currently present. If it stays over 6 months, the patient is chronic. Anti-HBs is the antibody against that surface. It means the patient has achieved immunity, either by fighting off the infection or getting the vaccine. HBeAg is a marker of high infectivity and active viral replication, while anti-HBe means lower infectivity. Finally, the core antibodies. IgM anti-HBC means an acute, current fight is happening right now, while IgG anti-HBC indicates past exposure.
But wait, here is where we run into a really fascinating medical mystery. As the patient is actively clearing the virus, the surface antigen, HBsAg, drops to 0. But it takes a little bit of time for the immune system to produce enough surface antibodies, anti-HBs, to actually show up on a test. So, what happens in that gap? How do we prove the patient actually has acute hepatitis B if both the primary antigen and the antibody are testing negative? That gap, that's called the window period. It is a highly tested, incredibly important concept. During the window period, the surface antigen is gone, and the surface antibody hasn't arrived yet. If you only tested those two, you'd think the patient was totally fine, but they aren't. During this crucial window, IgM anti-HBC is the only positive marker. That core antibody acts as the definitive footprint, basically proving that an acute hepatitis B infection is currently resolving in the background. If we were to take a liver biopsy and peek under the microscope, we'd see a literal cellular crime scene. We see ballooning degeneration, where the hepatocytes are all swollen and injured. We see Castleman bodies, which are these very distinct pink apoptotic, meaning programmed to die cells. We see bridging necrosis, where whole swaths of dead tissue connect the portal tracks. But the absolute most distinct clue? Ground glass hepatocytes. These are cells that look hazy and granular, and they are specifically caused by the massive accumulation of hepatitis B surface antigen. If you see ground glass, boom, you are looking at HBV.
The resolution, complications, treatment, and prevention.
So the absolutely crucial point here is that when these viruses aren't cleared, the consequences are devastating. In rare acute cases, like HEV in pregnancy, we see fulminant hepatic failure, massive, rapid liver death leading to brain swelling and the failure of the blood to clot. But the real long-term threat comes from chronic HBV and HCV. Years and years of persistent inflammation lead to fibrosis, which eventually destroys the liver's entire architecture, resulting in cirrhosis, complete with portal hypertension and fluid accumulating in the abdomen. And worst of all, this chronic damage from HBV and HCV is a primary driver of hepatocellular carcinoma, liver cancer. Notably, HBV can actually trigger this cancer even before cirrhosis fully develops.
So how do we actually fight back? For acute hepatitis, our approach is largely supportive: hydration, nutrition, profound rest, and absolutely zero alcohol. We essentially just support the liver while the immune system does all the heavy lifting. But for chronic cases, medicine has evolved remarkably. For chronic hepatitis B, we use powerful suppressive drugs like tenofovir or entecavir to halt viral replication. And for chronic hepatitis C, we have achieved a literal modern medical miracle. We now use direct-acting antivirals that actually cure HCV in the vast majority of patients today.
Of course, the absolute best treatment is preventing the infection from happening in the first place. This means ensuring safe blood transfusions, using sterile needles, practicing safe sex, and maintaining strict hand and water hygiene. But without a doubt, our greatest triumph in prevention is the hepatitis B vaccine. It's actually considered the first ever anti-cancer vaccine because it prevents the liver cancer that HBV directly causes. It is highly effective, it's included in standard global immunization schedules, and it is an absolute necessity for protecting healthcare workers and populations worldwide. And remember, by preventing HBV, we also completely eliminate the risk of the dependent HDV virus.
All right, let's lock in the most essential takeaways from our investigation today with a rapid-fire summary. Remember these pearls. Hepatitis B is the unique DNA virus carrying reverse transcriptase. Hepatitis C holds the highest rate of turning chronic. Hepatitis E is uniquely severe and life-threatening during pregnancy. Hepatitis D is a dependent virus that absolutely requires HBV to survive. And the IgM anti-HPC marker is your diagnostic hero for identifying an acute HPV infection, especially during that tricky window period. We've mapped out the incredible complexities of how these 5 very different viruses target the human liver. We now possess highly effective vaccines for hepatitis A and B. We've developed a literal cure for hepatitis C. The science is advancing faster than ever before. So I leave you with this. As our medical arsenal against these pathogens continues to grow, could we actually witness the total global eradication of viral hepatitis in our lifetime? Thank you so much for joining me on this explainer, and I really hope this deep dive clarifies the alphabet soup of the liver. Keep exploring.